We live in a society that goes to great lengths to avoid talking about death. Because of that avoidance, the word hospice carries a heavy, unspoken weight. For many families, it sounds like an admission of failure. It feels like abandonment, giving up, or reaching the absolute end of the line. That fear actively prevents people from accessing specialized medical support. A terminal illness can span years of intense treatments and hospital visits, but the national average length of stay in a hospice program is just 18 days. For a significant portion of the population, it is even shorter. 1 in 10 patients is enrolled in hospice for only 1 or 2 days before passing away. By delaying care until the last possible moment, terminally ill patients suffer through severe symptoms without specialized support. They miss out on months of a comprehensive, fully funded Medicare benefit designed specifically to keep them comfortable. Our healthcare system is built on the model of curative care. This is the standard medical approach, where every resource is directed towards fighting a disease and prolonging life at all costs. With terminal conditions like advanced dementia, heart failure, or cancer, the body eventually reaches a biological breaking point. At a certain stage, the physical toll of aggressive interventions, like heavy radiation, invasive surgeries, or continuous life support, begins to vastly outweigh any medical benefit. The treatment itself starts causing more pain than it relieves. So what happens when the medical system stops trying to cure a disease that can no longer be cured, and instead directs all of its expertise towards caring for the person? Pausing curative treatments is a deliberate medical decision. It is a calculated pivot away from fighting a losing battle with a disease toward prioritizing a patient's daily quality of life. To access hospice care, there is a strict medical threshold. 2 physicians, typically the patient's attending doctor and a hospice medical director, must certify that a patient has a terminal illness with a life expectancy of 6 months or less if the disease runs its normal course. At that point, the patient must make a conscious choice. To receive this Medicare benefit, they must agree to forego aggressive, life-prolonging treatments intended to cure their illness, and instead prioritize comfort measures. This approach traces back to the 1960s and a British physician named Dame Cicely Saunders. Working at St. Christopher's in London, she introduced a specific framework for how the medical community handles end-of-life care. Saunders argued that care must be holistic, treating physical pain, but also psychological and spiritual distress. Her guiding philosophy was that medical professionals should do everything they can not only to help a patient die peacefully, but to actively help them live until they die. From its inception, hospice was designed as a specialized, active medical discipline. It was built to provide rigorous care, rather than serving as a passive waiting room. Today, hospice is rarely a specific building. It is a mobile, interdisciplinary medical team that comes directly to wherever the patient calls home, whether that is a private residence, an assisted living facility, or a nursing home. This team operates in 3 layers. The foundation focuses on expert pain and symptom management. Second, social workers and chaplains step in to manage psychological and spiritual distress. Finally, the team supports the entire family ecosystem with caregiver training and bereavement counseling. By deploying this comprehensive, interdisciplinary team, hospice proves itself to be serious medicine. It treats the whole person and their surrounding community, rather than isolating and attacking a singular disease. This brings us to a frequent paradox of hospice care. When patients stop undergoing exhausting, aggressive treatments, their physical condition often stabilizes. In many cases, they actually feel significantly better. The biology behind this is straightforward. Removing the toxic side effects of curative treatments, like the severe nausea of chemotherapy or the extreme fatigue of radiation, allows the body to finally rest. Meanwhile, the hospice team's expert symptom management removes their baseline pain. Once that physical suffering is alleviated, patients frequently regain cognitive clarity and emotional presence. Families often get their loved one's personality back for those final months. Compare the environment of a hospital intensive care unit, with its chaotic alarms, strict visiting hours, and constant interruptions, to a quiet living room. Home-based care offers a controlled, peaceful, and autonomous environment. The ultimate value of hospice is reclaiming time and agency. It transforms what could be a frantic medical crisis into a protected period for closure, sharing memories, and preserving human connection. Patients who choose hospice are making a medical decision to prioritize dignity and comfort. They are stepping away from a biological cure that is no longer possible and reclaiming their final months. Help us break the societal stigma around the word hospice by sharing this video. Too many families are missing out on the support they deserve simply because they are afraid of what the word means. Be sure to subscribe and tune in tomorrow, where we will break down the exact medical and legal differences between hospice care and palliative care.